Hey there, and thank you for having me. My name is Elizabeth Thijssen, and I'm a researcher at Charlotte Teunis's lab in Amsterdam. And I'd like to share 3 of our projects with you, looking at the association between blood-based biomarkers and amyloid status. We're looking at amyloid A-beta 42 and 40, GFAP, neurofilament light, and phosphorylated tau. So a little bit of background of why we want to look into blood-based biomarkers. And I know I'm preaching to the choir here, but just a little recap. So medical doctors do really use knowing somebody's amyloid status for the diagnosis of Alzheimer's disease. Knowing the amyloid PET status has influenced medical doctors to make a decision on the diagnosis and on the treatment plan or the patient management. Also, it's critical for inclusion in clinical trials because often being amyloid positive is an inclusion criteria for participating in clinical trials. Currently, there are approved biomarkers, but they have their downsides. For instance, amyloid measurements and tau measurements in CSF, though taking lumbar puncture is invasive. And we use amyloid PET imaging, though this is very expensive and in a way invasive as well, using a radioactive tracer. Thanks to a lot of advancements in sensitivity for technologies in the field right now, we can measure quite a lot of blood-based biomarkers, looking into NFL, A-beta 42 and 40, measuring tau in blood, though phosphorylated tau has proven to be more promising, and now also GFAP. The first study that I'd like to share with you is a cohort analysis of about 260 patients, and we measured amyloid beta 42/40, took the ratio of that, GFAP, and neurofilament light. As you can see here, we try to cover a broader range of the amyloid pathology and the pathology that's involved in Alzheimer's disease, also including GFAP for the microglia, and focusing on a cohort of amyloid PET negative cases and amyloid PET positive cases, covering different clinical diagnoses. So our control group is subjective cognitive decline. Then we also have mild cognitive impairment and Alzheimer's disease. And Alzheimer's disease patients are all amyloid PET positive. As you can see here, all the 3 biomarkers show a significant difference between the amyloid PET negative and the amyloid PET positive group. With GFAP showing the highest area under the curve, then the ratio of amyloid 42 and 40, and then neurofilament light. When creating a composite panel of these markers, the strongest area under the curve was reached with the ratio of plasma amyloid 42 and 40, GFAP, and including age and the ApoE carrier status of the patient. NFL in this case did not have added value. With a sensitivity of 82%, specificity of 86%, and a total area on the curve of 88%. So the amyloid assay that we used here is one that we've developed about 2 years ago ourselves with a prototype, and then collaborated with ADX Neurosciences to create an assay that would be that we could upskill and in the end hopefully commercialize, so that other people and other labs can use it as well. I'd like to show the data of an assay comparison study that we did with multiple assays on the Simoa platform and one like traditional ELISA. So as I said, the prototype is one that we developed 2 years ago. Then the AmyBlot is based on the prototype but ready for upscaling. The Neuro3plex that is commercialized by Quanterix, and the traditional ELISA. Here we also stratified for amyloid positivity and negativity, but in this case based on CSF biomarkers, so CSF A-beta 42. We used, in this case, more like a control group of psychiatric patients that are amyloid negative, and again, subjective cognitive decline, and AD cases that were the positive group, all of them being amyloid positive. And as you can see here, all the 4 assays, so our prototype, the AmyBlood, the Quanterix assay, and the ELISA assay, could significantly differentiate amyloid CSF negative from amyloid CSF positive cases measured in plasma. What has been interesting is to see that there is a strong correlation, at least between the prototype and the upscalable AmyBlood assay, as expected, because they are using the same antibodies, but also between our AmyBlood assay and the Quanterix assay, which is probably using different antibodies than ours is. All of them are very good on the percentage CV level, though. So promising data. Now I want to make a step and jump into phosphorylated tau, not measured with the Quanterix machine, but with MSD. And we did this in collaboration with Eli Lilly when I was working at UCSF. And the aim was to look a little further than only normal control, mild cognitive impairment, and AD, but also look into FTLD and see whether this biomarker perhaps is increased in FTLD cases versus Alzheimer's disease and MCI. And we also wanted to relate these, what we measured in plasma, with more traditional approved biomarkers of amyloid imaging. This is quite a large cohort of 362 patients, 69 healthy controls, 56 Alzheimer's dementia, 47 mild cognitive impairment, and then a large group of different syndromes in the FTLD spectrum. So CBS, PSP, BV-FTD, and PPA. We have plasma phosphorylated tau measurements in all of them, and we want to relate it to what we measure with neurofilament light. And then we had a large subset with amyloid PET imaging as well. And what you can see here is that phosphorylated tau is largely increased in AD patients, clinical AD, compared to all other diagnoses. The fold increase of AD versus normal control is a 3.5-fold. So it's a very large increase. What's also interesting to see is that this phosphorylated tau is not increased in these FTLD cases. Whereas when we measure neurofilament light, it is increased in FTLD compared to the normal controls, MCI, and AD cases. And what is nice to see as well is that we do see an increase in AD, a neurofilament light, compared to controls. It's just not as spectacular as you can see in the FTLD group. Phosphorylated tau also identifies amyloid PET positive cases compared to amyloid PET negative cases, regardless of their clinical diagnosis. So as you can see, both the amyloid positive group and negative group has some FTLD cases, but also some controls in there. I added two slides after a discussion at the table yesterday evening, because people were asking me, so is phosphorylated tau early enough? Like, can it measure already when there's like a limited disease severity? And I think it's interesting to see, like, these are small groups, but already in mild cognitive impairment, you can identify amyloid PET positive cases. And these are the cases that can be enrolled in clinical trials. These are the cases that might benefit from a different disease, like clinical management. Even in the normal, like, healthy control group, we can identify the amyloid PET positive cases. So if we want to make this a screening biomarker that might already be of help in the doctor's office, perhaps phosphorylated tau can help us here. I think the conclusion for now is that ultrasensitive technologies such as the Simoa machine have made biomarker analysis in plasma possible, but also clinically relevant. From now on, we'll have to look into clinical validation in multiple independent cohorts that is essential to clear the path for clinical implementation. This work has been done with a tremendous group of people. Like, it's a lot of collaboration with pharma, with academia, different academia, biotechnology, just like ADX Neurosciences. So I want to thank them, and I want to thank you for your attention.